So I believe we all remember this diagram from our textbook, which is showing the axial skeleton and the appendicular skeleton. Axial means axis in the midline. So those structures, those bones in the midline, they will be in the axial skeleton, which means our skull. In other words, it is cranium and the facial bone and the mandible. And our cervical spine, so the spine for the neck, the spine for the thoracic region, thoracic spine, and lumbar spine, and down to the pelvis, which is sacrum. So all these in line in the center of the axis, this is what we call axial skeleton. And don't forget our ribs, although they are coming out of these axial skeleton, but because they are going to the front and going to the sternum, so they are again in the axial skeleton. If you look at the mandible is manubrum sternum, our chest bone here in the center, it is color with green, which means it is in the axial skeleton. So from the front, we need to remember our clavicle, collarbone. Clavicle is not part of the axial skeleton. And from the back, we can see the skull, cervical spine, thoracic spine, and lumbar spine for our low back, and the sacrum. It is in the axial skeleton, but the scapula, which we study quite a bit, is not in the axial skeleton. So yes, at the front, clavicle is not part of the axial skeleton, but sternum is part of the axial skeleton. So if we can remember that the rest of the bones we have in our body, it is out of the axial skeleton, and we will say they are in the appendicular skeleton. So like our humerus bone, the arm bone, the forearm bones like radius and ulna. Radius is on the lateral side and ulna is on the medial side. Medial means closer to the body, lateral means farther away from the body. So in anatomical position, radius is lateral and ulna is medial. Radius and ulna and the hand, the bones of our hands, they are all in the appendicular skeleton. But at the same time, even we make a big pelvis with our sacrum and two pelvic bone, only the sacrum is in the midline, and therefore only the sacrum is in the axial skeleton. The rest of the pelvic bone, they are out of the axial skeleton. They are in the appendicular skeleton. And our femur, I believe we all know femur. Femur means our thigh bone. And in our leg, we have big bone, tibia, which is on the medial side, and small bone on the lateral side, fibula, tibia and fibula, and all the bones in our foot and ankle, they are all in the appendicular skeleton. So by looking at that, to good extent, we learn which bone is what. So let's go and look like skull bone. Let's go and dig into axial skeleton today. Skull bone, as we know, the skull bones are flat bones. And they are many different pieces attached to each other, like our roof, like small little pieces of sheets, they just cover on each other. The same thing, like our cranium, our skull bone is made of multiple flat bones, and they are attached to each other. And I believe we can remember when we talk about the joints, the bones are interdigitating into each other, and the cartilage, fibrous tissue, will be crossing this bone, and this joint is called suture joint. So the skull bones, many different pieces attached to each other, interdigitating each other, and these joints are called sutures. So because many different bones form the cranium and the skull bone, and we are going to get many different joints. They are all the same suture joints. You can see, they are interdigitating each other. suture joints. So we will have many different joints in our cranium. Before we talk about the names of the suture, let's talk about the bones, the flat bones, which make the cranium. So yeah, on our forehead, that forehead bone is called frontal bone. Forehead bone is frontal bone. And the bone in the back, like where our occiput is at the back, it is called occipital bone. So easy to remember at the occiput, occipital bone, in the forehead, frontal bone. And those big bones on the side of the skull, which is up here, that is parietal bone. And this small little bone just above our ear, just above around our ear. So this is going to be the place for our external ear, the elastic cartilage external ear. So just above the external ear, this bone we can see, which is what we call temporal bone. So frontal bone at the front on the forehead, occipital bone, occiput, we all know that. The big bone on the side is called parietal bone. And this small bone just above the ear, this area, that is what we call temporal bone. So don't worry about the sutures yet. Let's pick up the names of the bone. At the front on the forehead is called frontal bone. At the back, where the occiput is, occipital bone. And the side of the cranium, parietal bone. So one parietal bone on the right side, another parietal bone on the other side. And just above the ear, there is another bone, which is not very big. It is called temporal bone. So this temporal bone is important because, let's say if someone have a fall and hit the head on the side, and this temporal bone is not a very thick bone. It is not a very strong bone. It is a thin bone. And if we hit that area, that bone can fracture easily. And if the bone fracture, there is a associating underlying artery which can rupture, and that will give us an intracranial bleed, the bleeding inside the cranium, inside the skull. So this temporal bone is clinically important because if there is any damage to this around here, had a fall on the side, hit the head on the side around the temporal region, initially they might lose consciousness. Then within a few minutes they recover as if nothing happened, and then but the injury is inside, the bleeding starts, and then the bleeding gets bigger and bigger inside the cranium, and the patient's neurological condition, awakeness, alertness go down. So that is what we call, lucid interval. So hit the head for lose consciousness, regain consciousness with as if nothing happened. That is what we call lucid interval. So this sort of scenario, be careful with the temporal bone because it is not a very thick bone. Of course, this temporal bone has got thick portion and thin portion as well. In this area, the temporal bone is not very thick at all. It is pretty thin and flimsy. Right, so try to pick up frontal bone, occipital bone, parietal bone, and temporal bone.
Professor.
Yeah.
Quick question.
Yep.
So how does certain people manage? Like, there's been people that have got stuck in their head, and they haven't had any damage when it comes to the brain. Like, what parts of the brain, if something got stuck inside there, it wouldn't damage them as much, or what area would damage them more if it hit certain parts? Because I would think if people get a nail or something really thick inside their brain by mistake, through an accident or something, they would get damaged. But I've seen people some really bad stuff and they didn't really have an injury. How is that?
You mean like the extent of the injury and the brain damage?
Yeah, exactly.
Yeah, I mean, so the brain tissue is, it is very delicate. And you, in the later lectures, when we go to the CNS, some part of the brain, the neurons are very concentrated. So if we damage that part of the area, like for those patients, like stroke patient, because one side of the brain, I believe we know, they control the opposite side of the human body, isn't it? So that's the whole brain, part of the brain has to come across a very little canal, very little area. So all the motor fibers and sensory fibers are concentrated in that area. So with a little damage to that area, the whole body on the side, we will lose. And like, again, like there are many different level of brain injury, like which we usually say concussion, contusion, laceration. So concussion means like, when we get involved in a minor road traffic accident, our brain is shocked like that. So concussion means it is just moved inside. So they might get headache, a little bit of uneasiness, or might be a little bit depressed for a few days to weeks. That is what we call concussion. I mean, the structural integrity wasn't damaged. Contusion means there is a brain damage, bruising inside the brain already. So that will take a longer time. And depending on which part of the brain, like, much bigger area in the parietal lobe of the brain, it is such a large area to supply. So if we damage the brain in the parietal lobe, it might be just a particular portion of the body. But if we damage that concentrated area, which is what we call internal capsule, then if we damage that area, like we get a stroke like that, on the whole part of the body is gone. So
Thank you, Professor.
yeah. So just, I'm going to repeat that again. Frontal, forehead, this bone, it is such a large bone in the front of our hood, on the car, like this occiput, and the parietal is on each side. So we only have one frontal, one occipital, but right parietal bone, left parietal bone, and right temporal bone, and we will have left temporal bone, which is just above our ear. So just be careful with temporal bone, which is a little bit fragile. And here, this little bone, we difficult to appreciate. That is what we call sphenoid bone. Sphenoid bone, if you look from outside, you are not going to see much, isn't it? Not much we can see from outside, but it contributes a big portion inside the cranium. So we will see that only when we lift up this cranium and look inside the base of the skull. Suture joints, I hope you remember the suture joints, the name of the suture joints. No, don't worry about that yet, because it is too much. So lambdoid suture, squamous suture, and coronal suture. I believe, it's easy to remember coronal suture. Why is it easy? Because it is in our coronal plane, isn't it? When we do the surgical CT scan or MRI scan, we look from the front, we get the body in this direction, anterior to posterior. It is what we call coronal section. Therefore, this suture is called coronal suture, not a new name for us. But squamous suture, forget about. Lambdoid, forget about that. That is the cranium, the bones of the cranium, and this is the bones of your face. So there is a difference, like when we talk about the head and face injury, that there is a difference between the cranial injury and facial injury. So facial injury, it is our mandible, is our face, part of the facial bone, and the maxilla, so the upper teeth, this nose, that portion of the face is in the facial bone, but the forehead is in our cranium. So the difference, cranial fracture or facial fracture, facial injury. Okay, it's too much. Let's go to next page, even worse. But I'm going to talk about the same thing, just looking in a different picture, different diagram, and just talking the same thing. So frontal bone, you know that this golden color, frontal bone. Parietal bone, you know this parietal bone, yeah? Red wine color, magenta color. And this occipital bone is here, the brown color. And temporal bone is here. Where is temporal bone? Here, temporal bone is here. What color will you say, this one? Can somebody help me? This temporal bone color?
Orange?
Yeah, orange, yeah. And here is the little bone, what we call sphenoid bone, yeah? Sphenoid bone, sphenoid means wings. Sphenoid bone, if you look from outside, it is so small, you don't even appreciate this is another segment of bone. But inside, it is pretty big and pretty important. And if you look at this temporal bone, which is in the temporal region, so that's why, you know, we say, hey, injury to the temporal region, that's temporal bone area. That's what we are trying to imply. And that's the clinical significance is that, because there is a meningeal artery, which is running somewhere around here. And if we hit it, that artery will bleed inside. And if you look at this temporal bone, this is here, external acoustic meatus. I mean, this is where our ear is going to, our elastic ear is going to attach in this region. And this part of the bone is really, really thick bone. That is what we call petrous portion of the temporal bone. You remember General Petrosa? Yeah, I do. I'm not sure where he got his name from, but petrous means thick and hard. So if you follow this external acoustic meatus, so if we remove our ear cartilage and the bone, if you follow the bones inside the cranium, that will lead to the very thick, dense bone, which is going into the cranium. And that is what we call petrous temporal bone. Petrous means hard and thick. So petrous is a Latin word, you know, petrous means hard and thick, and the bone is really hard and thick. So some people like archaeologists, so from the ancient, like cadaver or mummies or something like that, they take this piece of bone from petrous temporal region to look for the DNA as well. I'm not sure they still do that. They were doing that like in 2010 somewhere. And this bone, they have given the name squamous suture. This part of the bone is, as I say, it is thin and flat. And therefore, what do we call thin and flat? Thin and flat cells, we call it squamous, isn't it? Scaly, just like a scale, flat, squamous epithelium. This portion of the temporal bone, we will call squamous temporal bone. And this portion of the bone, especially inside, if we go along the external ear, into the middle ear, into the inner ear, into the cranium, the bone is really thick and hard. And that is what we call petrous temporal bone. Mandible, we all know that mandible, but we all have angle of the mandible. And that's the facial bone. Facial bone is what we call maxilla. And this petrous, that temporal bone is like a projecting on the one limb here. That is what we call zygomactic process. Process means something coming out, process. And this is the zygomactic bone. So when we talk about facial injury, facial fracture, we will be talking about this portion. When we talk about cranial injury, we'll be talking about the portion from here to the back. Let's move on. The same thing, but now I have done the sagittal section so that I can see inner half of the cranium now. we can still appreciate this frontal bone here, which is colored with gold yellow. And we can see this is the parietal bone and this occipital bone here in the back. We are seeing the opposite opposite temporal bone from inside. And that's pink. This pink, what we call sphenoid bone, the little piece we can see from outside. It's pretty big here, inside here. It contributes to a lot of inner portion of the brain, which is called sphenoid bone. And you can see here, this little hollow here, like a U-shape socket or little cap. That is what we call sella, S-E-L-L-A, sella. Here, sella tasica. I mean, tasica means sella means depression, little pocket. Tasica means it comes from the Turkey. So, because it is they think it is look like a little pocket or the depression where the Turkish sits. So that is sella tasica. In this here, little socket, we have our pituitary gland. So pituitary gland, I believe, if you are doing physiology, you will have to study about, when we talk about the endocrine system, pituitary, we have to talk about. Pituitary gland is important. But what is important? It is just like a small little piece, like a peanut. It is sitting here. It does a lot of function. It controls our body. And it is sitting in just this little sella tasica, which is part of the sphenoid bone. And that sphenoid bone, if we look from outside, it is just nothing, like you don't even appreciate it is a piece of bone, but it contributes such a big area inside the cranium. And therefore, if we want to do pituitary operation, pituitary surgery, we can go through our mouth and go to the sella tasica. Hey, it's not far. Or we can go from the nose, through the nose, and then go to the sella tasica. It's not far. It is pretty much direct. Instead of going through the big and damaging the big brain, which is going to sit around here, we can't do that. So we have to go. We have to find a way to do surgery on pituitary. And if we want to do surgery on pituitary, we just open the mouth of the patient, go to the back of the oral cavity, and go and dig into the sella tasica, and go through the nose, transnasal through the nose, or transoral through the oropharynx, and go to the sella tasica. That's the way we do pituitary surgery. So they're different picture, the same thing. Again, like different picture, but we're going to talk about the same thing. You can appreciate the sella tasica, which is, well, of course, not as obvious as the diagram. And you can see the frontal bone, parietal bone, and occipital bone, mandible. Yeah. Okay, so now I'm going to push the skull back. So which is the same here, or might be the same like this one. But yeah, let's have a look. So to start with, we will go back to what we know, just to ease ourselves. Frontal bone here at the forehead, occipital bone at the back, occiput here at the back. Parietal bone, where is parietal bone? Is here on the side. And now you can appreciate the temporal bone, which there is a junction between the temporal and the parietal bone. Temporal bone, part of the temporal bone is external acoustic meatus or outer ear. From the temporal bone, there is a process which will come out from the temporal bone towards the face. That is what we call zygomatic process, zygoma. And that zygomatic process will form the zygomatic bone. So zygomatic bone is our cheekbone. Mandible, angle of the mandible. This is the upper lip. If we remove the upper lip, this is what we are going to see, maxilla, and the nasal bone here. Yes, so the coronal suture, you know that because it is in the coronal plane. Coronal plane means slicing the body from front to back, 1 slice, 2 slice, 3 slice, 4 slice. So this is coronal plane is in the coronal section. Therefore, we will say coronal plane, coronal suture. And the junction between the parietal bone and the temporal bone, because temporal bone is flat and thin, it is the squamous portion of the temporal bone. And here, thick portion is called petrous portion, general petrosa, hard, thick bone. So petrous portion of the temporal bone, and this is squamous portion of the temporal bone, come and join the parietal bone. Parietal bone is thick, and this junction, temporal parietal junction, is called, because squamous bone, we will appreciate that squamous suture. Right, let's move on. So now we are going to look the skull cranium from the back. So this cadaver or the cranium is in anatomical position. It is we are behind that anatomical position, yeah. And this is the right side. This is the left side. Now we can see the parietal bone on the left, and we can see the parietal bone on the right. Hey, look at the two parietal bones are joining in the midline. What is the midline section? What do we call?
Sagittal.
Sagittal, yeah, so we will give the name. This is in the midline, sagittal suture. Yeah, so coronal suture and sagittal suture, they are not difficult for you. So because it is sliding the body from right and left, right and left, right and left. So this is mid-sagittal. If we cut it here, this is will be parasagittal. So para means on this either side, parasagittal here. And this is mid-sagittal, but we don't say mid-sagittal, we say sagittal suture. So one left parietal bone and right parietal bone. Don't forget right and left, because this is anatomy, and the cadaver or whatever you see is in anatomical position. It is you and me who is rotating around the patient or the cadaver. So this is left parietal, and this is right parietal, sagittal suture. And the suture between the occipital bone and the parietal suture is called lambdoid suture. Lambdoid suture, that name is a little bit, have to swallow it, you know. Lambdoid suture, but every bone we can appreciate now the suture. What is a suture joint? A suture joint is a fibrous joint interconnecting each other. The bones are interlacing each other. And occiput, you know, this occipital bone, this big band, that is something we can feel in our cranium. And that's what these are, the ridges, bony ridges on the lower part of the occipital bone, which we will find it difficult to feel it with our hands. These are the ridges, nuchal line, superior nuchal line, inferior nuchal line. Why do these ridges happen? Because the muscles from the back has to come and attach to to the back of our head. That's why these are the bony ridges, rough area for the muscle to grab properly. And you can see the occipital condyle, which is a condyle means little bump of bone. I mean, this occipital condyle on the left side and occipital condyle on the right side. So this lower part of the occipital bone, we have a condyle just to sit on our spine and try to move like that. Okay, let's open the cranium. Let's look onto the floor of the cranium. So this is the frontal portion. And this is the occipital portion. This is parietal portion and temporal portion. And this is the left temporal and parietal portion. Now we can see the inside of the cranium. We are looking from the top. This is the right side. This is the left side. And you can see a big hole here because our brain is going to sit here, fill the cranium, fill the skull bone. And this brain from our cranium needs to come out as a spinal cord and go into our spine, down to the lumbar region. The spinal cord ran to the lumbar region. So it has an outlet, the brain's outlet, through this foramen to continue as a spinal cord in our spine. And this foramen is called foramen magnum. We come in later. But in this picture, we will be simple. We'll be a simple student to study anatomy. And we will divide the floor or base of the cranium inside into three portions. Anterior portion, we call anterior cranial fossa. Middle portion, we say middle cranial fossa. And posterior portion, we will say posterior cranial fossa. And therefore, don't forget our foramen magnum. Foramen magnum is in the posterior cranial fossa. And our sella dacica, which will be here, like they have marked with the little dotted, that is a sphenoid bone. So sella dacica will be somewhere around here. So our pituitary gland will be in the middle cranial fossa. And anterior cranial fossa, we will have the frontal lobe of the brain, sitting frontal lobe of the brain. Okay, that's the basic, and it is not difficult, but let's go and have a look. The same picture, but it is a little bit more elaborated, more complex. If you don't know, like it will be a little bit daunting. If you don't know, start with the foramen magnum. Big hole, big foramen magnum. Foramen means big hole, foramen magnum, magnus, big hole, foramen magnum. And now you can appreciate the posterior cranial fossa. And you can appreciate the anterior cranial fossa in between. We will say like two little pockets, which is what we call middle cranial fossa. And here we can say sella dacica, which is somewhere around here, which is hypophyseal fossa, or sella dacica, hypophyseal fossa, hypophysis, which is in other words called pituitary gland. So pituitary gland fossa is here, posterior cranium, middle cranial fossa, and anterior cranial fossa. Yeah, so you can see a big hole, and this is the frontal bone. This is the back occipital bone. On either side, we have upper parietal and lower temporal, upper temporal and lower parietal. So if we know the big fossa, opening aperture, the foramen magnum, do you want to know these small little names? Of course I do. Yeah, I do want to know the names of these little aperture, because these little apertures from the brain inside the cranium, all the nerve and blood vessel from the brain will come out through these little holes in the base of on the floor of the brain, and the brain structures will come out as a cranial nerve and to go to the different part of the body to give supply. Yeah, foramen magnum, it is big, so we have a big spinal cord will come out. It is easy, guys, it is easy. So we will have a few apertures of foramen on one side, on right side, the same thing on the left side. So let's stick with the right side. Here, the little opening closest to the midline, we call foramen lacerum. Lacerum means lacerated. It is like a torn. Like if you torn your clothes, like just rip it. That's like a little ragged hole. It is not smooth. It is lacerated. Therefore, we will say foramen lacerum. And go slightly outside. We will see a nice and rounded and oval shape little hole. It is very smooth. It is very smooth. Nice and rounded. That is what we call foramen ovale, oval shape, foramen ovale. And now, if we go slightly more outside, that is a little spiny spicule. Hey, it is what we call foramen spinosum. So now you remember 4 holes at the base or floor of the cranium, which is coming out, which is giving the passage for the brain contents coming out like a cranial nerve, coming out from the brain cranium into your body. Like big hole is big, mean magnus, hole, aperture, for foramen magnum is big one. But small little 3, I want you to remember these 3. The closest to the midline is lacerated, therefore we will say foramen lacerum. And something is lacerated, something is need to be nice and smooth and round and oval, foramen ovale, and little very tiny little foramen spinosum. Professor talked too much. What is this? Jugular foramen. Okay, our jugular vein, internal jugular vein. I believe you have heard of that, jugular vein. We have to come out through the jugular foramen. Okay, so yeah, this diagram makes a lot of sense now. Anterior cranial fossa, middle cranial fossa, posterior cranial fossa. In the posterior cranial fossa, we have foramen magnum. In the center, there will be 3 little apertures or foramens, which we should remember. The most closer to the midline is lacerated shape. It is foramen lacerum. Become nice and smooth and oval shape, foramen ovale. Little tiny spicule, foramen spinosum. Hey, big foramen magnum has another big opening, which is what we call jugular foramen. It is for jugular vein to go out from the brain. Forget about that. Let's move on to next. Again, like the same picture, we have cut the cranium in the axial section. We open the vault of the cranium and we look inside the floor of the cranium or base of the cranium and we can see the golden yellow frontal bone, which is making the anterior cranial fossa, the brown bone, which is making the occipital bone, which is making the posterior cranial fossa, and middle cranial fossa, which is the combination of temporal bone and sphenoid bone. I said, you know, sphenoid bone has got big portion inside the brain, but look from outside, it's very tiny, small little area. Yeah, so it is quite big here inside. And we remember the very first picture, the sphenoid bone is like as if like a little peanut, but it is pretty big and it gives a place for the pituitary gland. A place is called hypophyseal fossa in the region of sella turcica. And we can appreciate 3 openings. Foramen lacerum is most central. Ovale is oval shape, and spinosum little tiny spinous. Jugular foramen here, foramen magnum here. So that makes a cranium, you know, because these openings are important so that we have connection between our brain and different part of the body. So now I have flip up. So now I'm looking from the top. So I just flip up the cranium and I will look from the bottom. So inferior view, inferior bottom of the skull to look upwards. And now you can still see the foramen magnum. That's why if I say, you know, if you don't know the skull bone, you start with the foramen magnum. And you start with the anterior cranial fossa, middle cranial fossa, posterior cranial fossa. And that will be the beginning so that you start the smooth and you start to remember things. I believe in a few days you will forget this. Doesn't really matter. We all forget it. We have to come back and can remember again. And finally, when you finish anatomy class, even if you want to forget it, you might not forget it. It just come back in your brain. It's just a repetition. So now looking at the frontal bone, we cannot see the frontal bone here now. They have removed it, but we can still see the occipital bone here. And we can see the condyles. That is what we call occipital condyles. These are the bumps. So now we are looking at the bottom, and this is the right side, and this is the left side. It is still in anatomical position. It is who we are. We are standing from the bottom of the patient, looking at the cranium upwards. So this is the right occipital condyle and left occipital condyle. So these are the little bony bump. You can see the nice and smoothness, which will rock, which will give the cranium rock on the spine. That is the region, we can say yes, 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 yes. If we do not have occipital condyle, we won't be able to say yes. We will have to say no, no, no. So temporal bone, you can still see that. And this portion, inner portion, is really hard, petrous. The portion of the temporal bone, which is close to the parietum, which is thin, squamous temporal bone. And you can see the jugular foramen here, which is close to the occipital condyle. And in the middle cranial fossa, you might see, spinosum, foramen ovale, and foramen lacerum. It is good to have a scar bone to have a look, but with this picture, I'm not going to go that far. And jugular foramen, don't forget, it is close to the occipital condyle. So therefore, in trauma patient like head and neck injury, if we see a fracture around the occipital condyle, we have to remember, is there any damage to the jugular foramen? Because jugular foramen, even the patient does not have any problem, even the patient is asymptomatic, not showing any problem. If there is injury to this area, yes, that injury can extend into the jugular foramen. Yeah, jugular foramen is important because all the blood from the brain will come out through the jugular foramen as a jugular vein to go back into the heart. What is more important? Well, or no, I should not say more important. What is equally important is the carotid canal here, which is here, carotid canal. So jugular foramen, just in front of the jugular foramen is carotid canal. I mean, the name tells what it is going to be inside. Carotid canal means the carotid artery from our heart. The carotid artery will go into the brain through the scar, base of the scar, through the carotid canal for the blood supply to the brain. So therefore, if we damage the occipital condyle, we worry about the jugular foramen. We should not forget the carotid artery. Might have carotid artery laceration, which is not significant enough to show immediately, but which might later complicate with the thrombosis of the carotid artery. Thrombosis means blood clot in that little laceration. So just the base of the brain, these little holes like foramen magnum, jugular foramen, and carotid foramen. Carotid foramen is for carotid artery, jugular for the blood supply to the brain, and jugular foramen is for the jugular vein, which is blood come out from the heart. They are all connected. Therefore, base of the scar fracture, it is really important, this anatomy knowledge. As I say, if you don't know anything, just start with the foramen magnum, and one after another things will come up in your brain. So let's look at the jaw. Mandible. We should not say jaw, we should say mandible. because we are learning anatomy. Mandible, body of the mandible. So that is here, body of the mandible. Its angle upwards, that is what we call angle of the mandible or mandibular angle. And the portion going upwards is called ramus. And that's become a condyle. So mandible, I will just leave it there. It is not difficult. Body of the mandible, angle of the mandible is not a difficult name, and ramus of the mandible, and become the condylar process. So this is the condyle, temporal, which will make the temporal mandibular joint. So movement of the jaw, yeah. So that is the mandible. And so this is again like, it's just irritating you again and again, isn't it? It just came back again and came back again. And this is the inferior aspect of the base of the skull. And if you don't know the cranium, and if you see an opening very big, then that is the start. That is a good region to start. That is the foramen magnum. If you remember foramen magnum, you should remember the two bump here on either side of the foramen magnum, which is what we call occipital condyle. If you go slightly more outwards or lateral, you will see the jugular foramen. The little opening in front of the jugular foramen is called carotid canal. Can you say carotid foramen? Yeah, you can, but they said carotid canal. So carotid canal and jugular foramen. And now you can see the lacerated opening, foramen lacerum, and oval opening, foramen oval, and little tiny puncture, spinous, spiky ones, foramen spinosum. Yeah, so now the skull base is not as difficult as we think. So now let's go to I will give you a break in a few minutes. Let's start the next process. So the brain, the cranium, the facial bone, and the bone come out as the spinal column, isn't it? Spinal column. So we have many different regions, like in the neck region in anatomy, we will say cervical. Cervical means neck, cervical spine. And in the chest, at the back, thoracic spine. In the lower portion of the spine, it is called lumbar spine, lumbar region. And finally, it will become sacrum. And at the tip, it is becoming very small bone, which is what we call coccyx. So these terminologies are not new for you. Cervical spines, cervical portion of the spine, thoracic portion of the spine, lumbar portion of the spine, and sacrum, which is in the axial skeleton. And at the lower end of the sacrum, we have the coccyx. So the cervical spine, like as you know, the spine, the whole spine is made of multiple individual cervical vertebra. So one vertebra on top of each other, that makes the whole cervical spine. In the cervical spine, we have 7 vertebrae. In the thoracic region, we have 12 thoracic vertebrae, and therefore we have 12 ribs in our body. So 12 thoracic vertebrae give a space for 12 ribs, 12 pairs of ribs on each side, 12 pairs of ribs coming out from each side. And in the lumbar region, it is only 5. Sacrum region, it is only 5. But sacral spines are fused already. Lumbar spine or thoracic or the cervical spine, they are not fused. There are one vertebrae, you put cartilage and fibrous tissue in between, another vertebrae, you put fibrous and cartilage vertebrae, and another vertebrae, you put, that is what we call disc, intervertebral disc, like disc problem. I believe we all heard of that. So bone and cartilage and bone and cartilage. Therefore, it becomes joint by definition. So these joints are, what sort of joints are they? Two bone covered with cartilage joined by the fibrous tissue. That is what we call symphysis. So vertebral body joints, the joint between each and every individual vertebrae, it is the symphyseal joint. It is like our symphysis pubic bone, symphyseal joint. And sacrum is like nearly fused already. Coccyx is very, very, very fused. And there are 4 little bones in the coccyx. They are all fused. If they are not fused, sometimes they can be irritating, like especially when we are sitting down, you know, those patients who coccyx are, especially the tip of the coccyx, they are not fused, or after they fall, and then they hit the coccyx, and then that coccyx got damaged. That is what we call coxalgia, coccyxalgia pain, coccyx pain. It is very difficult condition to treat because it's painful. You know, whenever you sit, it's painful. But on the other hand, do we really want to go and take it out? We can, but it is not a very soothing surgery. So not a good thing to do. So coccyx has 4 bones. So in total, how many bones do we have in our vertebra? 7, 12, 19. 19 plus 5 and 5. 19 plus 10, 29. Coccyx, we have 4 bones. So in total, 33 individual bones in our spinal column. All right, so but you know, of course, every portion is different. And we are designed, human body is very well programmed and designed to adapt to the function. So cervical spine, what do we need? What is the most important thing for the cervical spine to do? It is movement, isn't it? We look this side, we look that side, we look up, we look down. So the cervical spine, the main job, what I see is for the movement. So the design for the cervical spine vertebra will be different from the spine from the other rest of the cervical spine. So the same thing like thoracic spine. If you look at thoracic spine, its function is to make a thoracic cage to enclose the vital organs like our heart and lungs. So the function of the thoracic spine is not for movement. You don't want to move a lot in the thoracic spine. If you move a lot with the thoracic spine, the heart and lungs inside our thoracic cavity, they are going to move. You don't want that. So their function is to support and protect and give a space for the ribs to come out. Therefore, the thoracic spine, the shape and the function is different from the cervical spine. The same thing, lumbar spine, it is just mainly for like, you know, like bending forward, flexion, and bending backwards, extension. And then you don't want to move too much because just in front of the lumbar spine, we do have our abdominal cavity and we have abdominal viscera and pelvic viscera. So we don't want to move too much, but we want some degree of flexibility because the whole thoracic region is being rigid because we attach the vertebral body with the ribs, and at the front we attach the ribs together in the sternum. So the thoracic vertebra is pretty rigid already, thoracic spine region is. Therefore, we want some degree of flexibility, but not a lot. That's why this function is different. And sacrum, hey, we do not want any movement at all. Fused, all the sacrum, coccyx, forget about that. Let's fuse it. That makes it simple and functional to get. And don't forget, there will be 33 vertebrae in our spinal column. All right, so I will give you a break. It's nearly 1 hour. All right, guys. So we will meet 10 past 11. Just go and have a break. Go and have water, coffee. Please do come back.
Thank you.
Yeah. Please do come back. Yeah. Don't run away. Because if you have to read by yourself, it is too much.
What time are we coming back, Professor?
We'll take a 15 minutes break. So 10 past 11. Is that all right? Okay, guys, I hope you are back. So if not, let's just gently repeat what we are talking about when we are waiting for those guys to come back. We have 7 cervical vertebra, 12 thoracic vertebra, 5 lumbar vertebra, and 5 sacral vertebra. That's 4 coccyx vertebra, which is completely fused usually. Yeah. And as I say, you know, there was a question, very good question. What is the function of the lumbar spine? Of course, if you look at the lumbar spine, it's pretty much at the bottom already in the spine, because sacrum is going to attach with the pelvis, so it has some support already. So lumbar spine is the a region of the spine which has to take most weight. You know, our cranium, our cervical spine, and our thoracic spine. Thoracic spine is carrying many weights because it has ribs, it is attached to these sternum in the front. So the whole weight of the thorax is coming down into the spine. And then finally, you know, it is the lumbar spine which has to take the weight. Therefore, if someone has got problem with the back, where do we usually get? Of course, low back, isn't it? Low back means lumbar spine. That's why low back pain is very common medical problem. It is difficult because we get it. I mean, it is not surprising because it is taking the weight of every portion of the spine. They will come to the lumbar spine before it transfer the loads onto the pelvis and onto the lower limb. And if we look at this diagram, we are looking from the front. And if we look at this diagram, we are looking from the side. So in other words, looking from the side is lateral view. If we slide multiple slides into lateral view, we will get sagittal section. And this is looking from the front. It is called anterior view. But if we do multiple slides anterior view, we will say that is coronal section. Yeah, coronal section or anterior lateral view or sagittal section. So let's look at that. This is the MRI scan. This is the MRI scan of the lumbar spine. So these two, they are in same patient, and these two, they are in the same patient. As I say, you know, MRI scan is detect the hydrogen ion in the body. The machine, MRI machine, will stimulate the hydrogen ion so that the alignment of the hydrogen ion will change because of the machine. And that hydrogen ion alignment changes will generate energy, and that energy will be taken by the machine and create as a picture on the screen. That's what we see. And at the same time, the hydrogen ion, what is the most abundant hydrogen ion in our body? Of course, water, isn't it? Hydrogen ion is H2O, water. So most water, liquid ocean is going to be higher signal because it contains lots of hydrogen ion. Something like bone will be least, opposite to the fluid. So the blood in the blood or CSF, cerebrospinal fluid, inside the brain and circulating fluid, they will be bright, completely opposite to the bone. So if we look at this first two lumbar spine MRI scan, this is sagittal section. So if we said there are 5 vertebrae in the lumbar spine, if we don't know how to count, we have to check the sacrum. In this diagram, in this MRI scan, this might be the uppermost sacrum 1. This might be sacrum 2, because the shape is different from the lumbar spine. Lumbar spine shape is very much square. And this is now thin and small. This must be the sacrum 1. So this must be lumbar 5, lumbar 4, lumbar 3, lumbar 2, lumbar 1 vertebrae. That's the way we count. Because we know that sacrum is smaller portion of bone, and they are going to fuse to each other, and it is calf portion. So we will say, yes, this is the sacrum 1 and 5, 4, 3, 2, 1 lumbar. The same thing, sacrum here, 5, 4, 3, 2, 1 lumbar vertebrae. So lumbar 1, lumbar 2, lumbar 3, lumbar 4, lumbar 5. And this is the sacrum 1. So these two in one patient, which is normal. Why do we say normal? If you look at the posterior portion of the vertebra, you follow it. It is nice and smooth here. It is nice and smooth here, and then going into the sacrum. And on this slide, the black line is the spinal cord, which is running inside the spinal canal. And the fluid, which is white, that is the what we call cerebrospinal fluid. That is the fluid which is circulating inside the brain and the spinal cord. It is just like blood, which is circulating in the cardiovascular system. This cerebrospinal fluid, in short, CSF, cerebrospinal fluid, is circulating inside the brain and the spinal cord. It is not a large amount, but this is what it is give us a cushion because it circulates around the spinal cord. So if there is any movement, that it acts as a cushion. And in this signal, MRI signal, the CSF fluid is really white. In this, the CSF fluid is not as white here. But let's look at that here, what we are seeing on the second part of the MRI scan. In this patient, you can see the lumbar spine is straight, more straight. Here, straight lumbar spine, comparing to this nice and smooth and curved lumbar spine. Lumbar spine here is curved. This lumbar spine is really smooth, rigid, like straight line. It is not a normal, if there is a problem with the pain, that we guard ourselves and our lumbar spine becomes straight. In an easy normal position, lumbar spine is easy curvature, not a very big curve, but it is an easy curvature, smooth and nice. And what can you see? You can see a bump here in between two vertebrae, lumbar 4 and lumbar 5. You can see the space here, which is the disc, intervertebral disc. Inter means in between, vertebra means in between two vertebrae. There is a space, disc, like a cushion. So we have disc, intervertebral disc in every part of the body. And now here, the disc is a bit crushed already. And the disc is bulging out into the spinal canal. And if you look at that, the lumbar and the sacrum, the alignment here is nice and smooth here running. There is a step here. Yeah, you can see the step here. So that means this patient has got real problem with the back. This patient is not faking. It is not making complaints unnecessarily because we can see the underlying problem here. Of course, the pain need to be associated with this region. Let's say if the patient is complaining of pain somewhere around here, and if the problem is here, these clinical picture and neurological pictures are not related. So we would carefully ignore that. If the patient is complaining of pain somewhere around here, and if we see this problem, we know that there is a real problem with this patient. The lumbar spine is straight, it's not like smooth and curved. There is a big step here between the sacrum and the lumbar 5, and the disc between lumbar 4 and lumbar 5 is coming out, disc protrusion into the spinal canal. If it is too big, then it can squash the spinal cord, and we got paraplegia. So that is the sagittal scan of the MRI scan in a lumbar spine. If we have a cross section or on top superior view, of the spine. This is a typical thoracic vertebra. This is anterior in the front on the tummy side. This is posterior on the back. So at the back, anterior, we have the vertebral body, and two bony processes come out from vertebral body. That is what we call pedicle. And these pedicle will unite, go into the center again, unite as a lamina. So pedicle, anything come out from the vertebral body is called pedicle, and pedicle will fuse together in the midline. These going is called lamina. And you can see this where two pedicle and lamina meet, there is a lateral process coming out. That is what we call going transversely. That's why we will say transverse process. Yeah, transverse process, pedicle, lamina, and this is at the back, pointing backwards, which is what we call spinous process. So if we go back to the previous slide again, so these are the spinous processes. So these are the spinous processes. This is the vertebra. The pedicle will be here, lamina will be here. So this is a typical thoracic vertebra. And of course, it gives a little place for the ribs to attach to the vertebra. That is what we call articular facet for the ribs. Pedicle, lamina, transverse process, spinous process. Yes, if we cover with the disc, this is what we have. The disc has two portions, inside nucleus pulposus and outside fibrous annulus. Annulus fibrosis, fibrous tissue outside, and inner nuclei, what we call nucleus pulposus. So on the body of the vertebra, we will have the disc lying like that. Yeah. So that was the thoracic vertebra. Cervical vertebra, the shape changed. The shape of the cervical vertebra changed. It is not like thoracic or not like lumbar because its function is for movement and protection. Of course, for the protection, the spinal cord, when it comes out from the brain, the spinal cord is stay pretty big, and therefore its central cavity is also pretty big. Look at that. Look at the size of the whole of the cervical spine. And let's go back and look at the whole of the thoracic. Thoracic is small comparing to the cervical because many nerve fibers from the spinal cord leave the spinal cord for the upper limb already. Therefore, cervical spine canal is much bigger comparing to the other because the spinal cord is much bigger in the cervical spine region. But don't forget, we still have the what do you call that? The anterior body, which is not that prominent, and the lateral transverse process. We still have the transverse process, and we still have the pedicle and lamina, which is not typical here. This became posterior arch. Look at this. Look at this. We now have the lamina and the pedicle. This is cervical 2 because the first one is cervical 1 vertebra, very first vertebra, which is going to articulate with the cranium. Look at that, the first cervical vertebra, C1, it has got a facet or a place like a saucer. This place is for the occipital condyle, the bony bump around close to the foramen magnum, which sits on each side, and it is give us a joint for the nodding, nodding movement. Yeah, if you nod, yes, you need to have this occipital condyle from the skull and this mass, the the little saucer shape, only then it will rotate and we can say yes, yes, not. If we have fused this joint, we cannot say yes anymore. We can only say no. And this is cervical 2, which is not a typical cervical vertebra, but you look at that, we still have a big pointy portion called dens at the front. Let's look at that. Look at the anterior, this is cervical 2. Looking from the back, superior articular facet, we have it, superior articular facet, and spinous process is slightly different, not like a typical vertebra, thoracic vertebra. And you have a bony process coming from the anterior mass. That is what we call dens. If we look on the lateral view, this is cervical 2 because it has dens. You know, it has the very tall projection like a telescope coming out from the bony process. That is the landmark to identify the cervical 2 vertebra. So if we look at the MRI scan of the cervical spine, if we don't know, just go and pick up the cervical 2, because cervical 2 from the lateral view or sagittal view, it is pointing like that into the, going into the cervical 1 vertebra. So this, if this is the 2, then this will be cervical 3, 4, 5, 6, 7. That's the way we count. That's the way we count the cervical vertebra. So look at that. This is the brain here, which is coming out through the foramen magnum as a spinal cord, and surrounding the brain is white, which is what we call CSF, cerebrospinal fluid. And these are the cervical vertebra. This is cervical vertebra 2 because it has dens. Dens is the pointing, upper pointing process from the body of the cervical 2, which will go and fit around here in this region. Okay, that is the cervical 2 vertebra. And the rest of the cervical body, cervical vertebral body is going to be like this. Like other vertebral body, it will have the body of the vertebra, the pedicle and the lamina, pedicle and the lamina, transverse process. Not exactly the same, but pretty similar. The basic structure is the same. Body, pedicle, lamina, and spinous process. Transverse process coming out lateral. But don't forget, in the cervical vertebra, in the transverse process, we have the little holes here. This is the hole where the another artery, vertebral artery, is going to pass these holes to go into the brain from the back. Thoracic vertebra, we have seen it. We have the pedicle and lamina and the spinous process. Anything going out is called transverse process. And this is the lumbar vertebra. You know, it is not exactly the same, but pretty similar. If you look at that, the body of the lumbar vertebra is big, solid. And this is the pedicle, and this is the lamina and transverse process. The shape of the transverse process is not very identical, but hey, it is not bad. And that's the way our shape of the vertebra gradually change, going from the cervical, thoracic to lumbar vertebra. Yes, anything going out is spinous process. You can see this lumbar vertebra spinous process, only one. You can see thoracic vertebra spinous process, only one. And you can see the cervical vertebra going like, it is like a two-tang, like sprung. So that is the significant. And the shape of the vertebral body here, this is like a heart shape. This is like a oval shape. And this is small vertebral body, which is similar to the lumbar vertebra, but it is smaller and its transverse process as a whole, where the vertebral body is going to use it as a channel. Yeah, looking from the side as well, they are different shape. If you look at the lumbar vertebra, look at the shape, the function of the lumbar vertebra is to take all the weight from the top to the bottom before it can transfer onto the pelvis. Therefore, the vertebral body of the lumbar vertebra is, hey, pretty big and solid. Thoracic is not as big as lumbar, and cervical spine is, hey, just a small little fragment of bone, nothing more than that. And thoracic vertebra, because we have ribs, so it need to give an attachment site for the ribs here and there. Lumbar vertebra, they do not have it. So this is the first cervical vertebra. Like as we say, we have the articular facets for the occipital condyle to rock on top. And this is the second vertebra, cervical vertebra. We saw that dent, which is pointing from the bottom to the top. So this dent is going to sit here when they articulate each other. Okay, that's too much now. Let's try to take an easy bit. So all the vertebra, they are connected by the ligaments at the front of the vertebral body. That is what we call anterior, going along the spine, anterior longitudinal ligament. At the back of the vertebra, which is going along the spinal column, that's what we call posterior longitudinal ligament. So anterior longitudinal in the front, posterior longitudinal ligament in the back. And on the spinous processes, we have like supraspinous ligament, ligamentum flavum, and interspinous ligaments, in between the spine, interspinous ligament, ligamentum flavum, they are all running. Yeah, let's go to something a little bit more simple. Let's look at the lumbar vertebra. That is what we are going to see: vertebral body, spinous process, lamina pedicle, intervertebral disc. This is the easier picture for us to take. So now it's too much. I'm going to change different subject. So comparing to the axial skeleton and the cranium and the spinal column, these bones become so easy. Yeah, so the bone becomes so easy. Our arm bone, humerus. In the forearm, we have two bones. On the lateral radius, on the medial ulna in anatomical position, the bones of the hand, we talk about that later. Our thigh bone, big, long femur. In the leg, we have bigger bone in the medial side, which is tibia, and small little bone on the lateral side, which is fibula. Most of our body weight will go through the tibia, might be about 20% will go to the fibula. So fibula is actually not really for the weight bearing, but it will share some weight from the tibia. If we want it, we can take a piece of fibula bone to use as some other part of the body. So fibula, yes, it contributes to the weight bearing, but might be about 20%. And it is also for the muscle attachment in the leg. Hey, I believe you all remember these bones already. Yeah, humerus, radius ulna, femur, tibia, and fibula. So let's look at the bones in our hand and wrist. Yeah, so radius and ulna, don't forget that, radius and ulna. We are going to look at this area. Yeah, this area. We are going to look at this area, the hand and the wrist and lower end of the radius. And look at that. The radius and ulna. This is our thumb side. This is our little finger side. And we can see small little bones inside our wrist. That is what we call carpal bones. C-A-R-P-A-L, carpal bones. and they are arranged in 2 rows. 4 bones in the first row, another 4 bones in the second row. So carpal bones are arranged in 2 rows. And after the carpal bones, this is what we call metacarpals. Metacarpal is the bones on the hand. That is metacarpal. Yeah, these are the metacarpal bones. And the bones in the fingers, they are phalanges. 3 bones, 3 phalanges in 1 digit, except thumb. So this is more proximal. So proximal phalanx, middle phalanx, and distal phalanx. Proximal phalanx, middle phalanx, and distal phalanx. Proximal phalanx, middle phalanx, and distal phalanx. And for the little finger, metacarpal, proximal phalanx, middle phalanx, and distal phalanx. This is it. Proximal phalanx, middle phalanx, and distal phalanx. Of course, in our thumb, we only have 2 phalanx, proximal phalanx and distal phalanx. We do not have middle phalanx in our thumb because thumb is only 2 bones, and phalanx in the rest of the 4 bones, they are 3 bones. Yeah. And there are 2 rows, carpal and. So I know you guys are putting up quite a lot, but like every 3 times a week, might be about 2 hours, we have to absorb these. If it is too much, just try to relax, have a glass of water or coffee, just come back again. We need to move on. And I'm going to tell you about the bones in our wrist. So in our wrist means the bones in between the lower end of the radius and ulna and between the metacarpal. So these, I'm going to talk about carpal bones in the wrist. That is what we have. I show MRI scan because it is easier, it is more human. This is the lower end of the radius. This is the lower end of the ulna. These are 2 carpal rows, and these are the metacarpals of the hand. So as I say, 8 bones arranged in 2 rows. So 4 for the first row, 4 for the first row, another 4 for the second row. So the mnemonic we have to use, or we should use, is she looks too proud. That's the first rule. Try to catch her. Yeah, she looks too proud. She's too proud. She looks too proud. Try to catch her. Go and get her. She stands for scaphoid. Look at that here. This is the scaphoid. You are going from radius to ulna. She, scaphoid. Scaphoid means it is scaphoid, like a little boat-shaped scaphoid, like a little boat. Looks lunate. Lunate means moon, like it is like a half moon bay, the lunate moon. She looks too triquetrum. This name is a little bit difficult to remember. I always forget. Triquetrum. Proud, pisiform. Its name is pisiform, small bone, small little pisiform, which we cannot see in this section, which will be somewhere around here. So the first rule is she looks too proud. And second rule is try to catch her. Try means trapezium here. 2, trapezoid. Catch, capitate. And her means handmade. So now we know the small little wrist bone in our wrist, which are staying in between the radius ulna proximally and metacarpal bones of the hand distally. These are the bones. 2 rows arranged in 2 rows, 4 bones in first rows, another 4 bones in second row. She looks too proud, try to catch her. That's the mnemonic, which is easy to remember, I think. Hey, that's just for something to relax. It's too much, too many names for the whole morning within 2 hours. I can't cope. So I can cope. So I have to look at this diagram. So this is the surgical operation on the brain, on the skull, on the cranium. So what we have to do is we have to lift up the skin, which covers the cranium, skull bone. The skin which covers the skull bone is called scalp, S-C-A-L-P. We have to study about the scalp in later lecture. I will put it in the neurology lecture. So what we do, like we just shave a little bit when we want to make a cut in the skin and peel off the scalp from the cranium. So now we can see the cranium here. That is a brain surgery. This is a brain surgery. You can see the edge of the scalp being squeezed with the clips. Because our scalp is very vascular. If we have a cut on the scalp, it will bleed and bleed and bleed and loads because it is very richly supplied with blood vessels. And now we can see the cranium, which is the skull bone. Now we want to open this cranium to look inside the brain. So what do we do then? We use a small little bar to make a little hole, in the cranium. And what the next step is, we put a little spoon to push anything away attached to the cranium inside, like brains and meninges covering of the brains. We push them away. Now we feed a bigger spoon. So make it free. Make the cranium, skull bone free from the underlying brain and brain tissue and covering substances away. And we put the saw and we gradually move the saw again and again and gradually move the saw. And now the bone has been cut away and we can see the brain tissue here. We can see the brain tissue here, which is, of course, it is covered with the brain coverings, which are called meninges. That's the way we do the brain surgery. So just peel off the skin on top of the cranium. The skin is called scalp, S-C-A-L-P, scalp. Once the scalp has been lifted off, we can see the cranium. We make a small hole and then put this, from that little small hole, we push away all the structures attached to the cranium inside, and then we carefully cut the bone, lift up the bone. That is what we call craniotomy. Cranium, the skull bone, otomy, opening of the cranium, craniotomy. So that is the craniotomy. And now we have a chance to see the inside of the cranium. This is the brain, which is covered with the brain covering, which is what we call meninges. Yeah, so this is not a big thing for you guys now. The parietal bone and the temporal bone and part of the occipital bone, part of the frontal bones has been removed to see the brain inside. So yes, in the frontal bone region, we will have the frontal lobe of the brain. In the occipital bone region, we have the occipital lobe of the brain and cerebellum. And in the parietal bone, we have the parietal lobe of the brain. So the same names we are going to use because we cannot remember any more names. And in the temporal bone, we have the temporal lobe of the brain. Temporal lobe of the brain, parietal lobe of the brain, frontal lobe of the brain, occipital lobe of the brain. And that is, we have something we have to remember, the cerebellum. Don't worry about these because they will come back in the neurology lecture. And you remember the anterior cranial fossa, middle cranial fossa, and posterior cranial fossa. So looking at that's the coronal section of the face, facial bone. Our eye orbit, this is right eye, right orbit, and this is left orbit, and this is our oral cavity, and this is the cranial cavity, and this is our nose. Nasal cavity will be here. Orbit. That's easy, isn't it? Let's look at the face from the front. We are all the same if we strip off our cartilages and the skin. So this is our facial bone and part of the cranium. Looking from the front. Hey, look at the frontal bone. Hey, frontal bone here, which is big, isn't it? Frontal forehead, frontal bone. This is the orbit. This is the orbit, left orbit. Our eyes will sit inside here. Left eye, right orbit for the right eye. This is the nasal cavity, and that's the maxilla. Maxilla, which is part of the facial bone. This is the mandible. Right mandible, left mandible meet in the center. This is called mandible, symphysis of the mandible. There is a prominence, what we call mental prominence. That's not difficult because you have look at this picture from the previous slide, and you remember the zygomatic bone, which is coming from the zygomatic arch. Zygomatic process, which is coming from the temporal bone, and this is the parietal bone. Frontal bone is the forehead. Nearly done, guys, nearly done. That's the same, nothing changed, but I'm showing you the different picture, but it is all the same. It is just like you and me, it doesn't really matter when we strip off everything from our body. And if we just leave the scar, that is who we are going to be like. The orbit, right orbit for right eye, left orbit for left eye, the forehead, frontal bone, maxilla, and the mandible meet in the center, mental process. Nasal cavity. Just a little bit reminder about the temporal bone, which is in this region. Temporal bone, as we say, this portion of the temporal bone is pretty thin and scaly. That's why we will give a name, squamous temporal bone. And this part of the squam is going to be associated, is hard, and therefore we will say petrous temporal bone, general petrosa, try to remember, petrous, hard portion, big, thick, solid bone, petrous temporal portion. And menstrual process, I believe you will be able to feel your own menstrual process, which is just behind our ear. So if we lift up our ear to the front and the bony point around here, which is the menstrual process, we will be able to feel the menstrual process. Of course, bony process, it will give an origin, attachment to the muscles and ligament. And we can appreciate the zygomatic process, which is coming out from the temporal bone, going to the zygomatic bone, which is the cheekbone. And styloid process, again, like a little tiny spike hue coming out from the temporal bone. That will give us muscle attachment, a source for muscle attachment as well. Yeah, so that is a little bit more detail about the temporal bone. Let's go back to easy bits. Easy bits, the anterior or coronal view of this orbit, left orbit, right orbit, maxillary bone, and oral cavity. Now you can see the air-filled space. So the head cranium, if we just make with the fully solid bone, it will be very heavy. So we have to make it fill with some air to make it light. And these air sinuses will play a role with our respiration. So we have nasal sinuses around in the face and the forehead. This is in the maxillary region. That is what we call maxillary sinus. And here we call ethmoid sinus, maxillary sinus. So if somebody has sinusitis, mean inflammation of one of these nasal sinuses, so the pain around here on either side of the nose, that is the maxillary sinus, sinusitis. So pain somewhere around here, from the sinus, pain somewhere around here, ethmoid bone, ethmoid sinus, and so on and on and on. That's, if we do the scan, these are the areas we can see, like maxillary sinus, frontal bone, frontal sinus, ethmoid bone, ethmoid sinus. That is what we call inflammation of these sinus is called sinusitis. Itis, inflammation, sinusitis, inflammation of the sinuses. Yeah, so anatomy of the vertebra is important when we do surgery, like scoliosis. I believe you all have seen some form of scoliosis. Scoliosis means lateral rotation of the vertebra. You know, if we do not have scoliosis, means we have taken everything for granted. We have been so lucky. There are a few people who are not lucky enough, and their spine is not straight, not nice and smooth. Their spine is bendy and windy. That is what we call scoliosis, the lateral bending of the spine. And that is the correction. Like we want to make it straight, we have to correct it like that. And you can see the screws, a lot of screws going into the vertebral body and going into the position. And this rod, two rods, one on each side, holding it together to make it straight. That is a way we have to put the screws into the vertebral body. You have to push along the pedicle to make sure your screw tip is inside the body of the vertebra, not damaging the spinal cord in this picture. So this, if we do that, this spinal cord will got damaged, and there will be a like paralysis on the lower part of the spinal cord. So this is what not to do, and this is what to do. And this anatomy knowledge, you have to follow the pedicle along to make sure your screw is going into the vertebral body without damaging the spinal cord. So these ligaments can be again like anterior longitudinal ligament, posterior longitudinal ligament. In between the ligament is called, in spinous process is called interspinous ligament. And ligamentum flavum, flavum means yellow color ligament. And supraspinous ligament on top of the spinous process, supraspinous ligaments. Hey, you can see the MRI scan. It's easy now, easy for you. This is the sacrum because the shape is different from the lumbar vertebra. So this is the sacrum 1, sacrum 2, sacrum 3. This is lumbar 5, 4, 3, 2. Look at the disc in between the lumbar 2 and 3. It is nice and big height. 3 and 4, good size. And it is not bulking into the canal. Lumbar 4 and 5, look at it, is still good. What about the lumbar 5 and S1? And that is this vertebra is not as high as this one. It is weak already, and it is bulging into the spinal cord. That is what we call herniated nucleus pulposus. That is the disc herniation, which can be really painful, which can be really irritating. So now you can appreciate the spinal anatomy. Nice and smooth, nice and smooth, nice and smooth. No disc bulge, no disc bulge, no disc bulge. the disc is bulging into the spinal canal, which is irritating the cauda equina spinal nerves inside the spinal canal. It is irritating. The disc height is very good here, very good here, very good here. The disc height is not good comparing to the other disc because the water in the disc is gradually become lost. That is what we call dehydration of the disc. So the disc is, the height is gradually become narrowed because the one vertebra is compressed because we lost the height. The bone is squashing on the vertebra and the disc has to give way and come out. That is the herniated disc. So look at the cervical spine. That is the way arrangement. Look at the thoracic spine, their arrangement. And different portion. I don't want you to go too much worry about this diagram, but I have to show it because it is in our textbook and I think it is very informative. What is the difference between cervical vertebra, thoracic vertebra, and lumbar vertebra? It is nice to, if you have a time, just go and flip around in that region and try to appreciate what is this and why is that. Sacrum, like 5 pieces of bone being fused together. 1, 2, 3, 4, 5. 5 sacral bone fused together, and their apertures are slightly different. These apertures are called sacral foramina. Where is it? Sacral foramina, yes. That is from anterior view. This is from the posterior view. And coccyx, as we know, coccyx is made of 4 bones, completely fused, and tip of the coccyx. The rib cage coming from the thoracic spine, the ribs on the right and left, they change cartilage when we were young. This cartilage will come and fuse to the sternum. Many ribs will come and fuse in the midline, but not every, like 12 ribs and 11 ribs, they will not fuse in the center with the cartilage. So these become atypical ribs. The anatomy of the ribs, don't forget about that. We are not going to talk about that. Anatomy of the ribs, the way it articulates with the thoracic vertebra, we are not going to talk about that. But we talk about this already, typical thoracic vertebra, which has a body, pedicle, and lamina, and spinous process, and transverse process. And the rib is attaching to the thoracic vertebra in this fashion. That is the scoliosis. If we look from outside, you can see a hump here. You can see a prominence of the scapula here. The spine is not straight. If we have a straight spine, we don't really appreciate it because we take everything for granted. If we are not lucky, we can easily end up with this condition, scoliosis. And, because of the twisting, you can see the head is not sitting directly on the pelvis anymore. The weight of the head is going slightly on the opposite side. It is so painful and so difficult. And if we live long enough, if we live old enough, we will gradually, our spine will bend forward gradually. That is, forward bending of the spine is what we call kyphosis. Kyphosis, bending forward. Lateral bending is called scoliosis. Forward bending, you can see a big bump here because the spine is, instead of like that, it's bending like that already, and you can see the bump. That is what we call kyphosis. So we all will have some degree of kyphosis if we live long enough. And lordosis, lumbar spine is going forward. This happened with the pregnancy. Like when someone gets pregnant, because of the weight, we will have the lumbar lordosis. Usually we all have lumbar lordosis slightly, but when someone has pregnancy, their lumbar lordosis will get bigger and bigger. Lordosis, kyphosis, and scoliosis, these are little terminologies. Yeah, now come to the end of the lecture. So that is if you want to remember only one slice, this is a slide we have to take. Frontal bone, parietal bone, temporal bone, occipital bone. That little pinky, which is what we call sphenoid bone. And the rest is called the facial bone. Temporal bone come out as the maxillary process and become maxillary bone. Zygomatic process and come out as a zygomatic bone. The face bone, which is what we call the maxilla, the nasal bone, and the upper portion of the jaw, and this is the jawbone. Of course, when we are newborn, these bones are not fully fused yet. So this gives us a little space for the brain inside to grow. That is when we call anterior fontanelle and posterior fontanelle. Right, guys, that's the end of this morning lecture. Has anyone got any question? Is it too much?
Yeah, it's very specific.
Yeah. So, I'm glad that you guys are stay here, at least trying to listen. Might come in or might not come in. It doesn't really matter, but at least we have something, a rough idea. And not tomorrow, on Friday, I'm not going to teach anything new. So we are going to skip lymphatics and endocrine lecture. So I will go back to this lecture and the skeletal muscle tissue together. So we'll go back, just revise for Friday.
Sounds good.
Yeah, so we will not have anything new information. From Monday lecture, Wednesday lecture will be revised on Friday. So it will make it a little bit easier because you have heard about this already. It's very difficult to cope in a lecture room, like for 2 hours. So I cannot, for myself, I'm taking some lectures, and after 1 hour, I cannot cope. So I just let it go. I just listen and just remember the name comes in and out of my brain. Let it go, let it flow, and then go back and revise again. So once we have, at least we have some rough idea already. When we go back, it will be a lot easier, I promise. So, all right then. Any more question? All right. So in that case, I will let you go. I will let you go.
Thank you, Professor. See you Friday.
See you.
Thank you, Professor.
Bye-bye, Jacqueline.
Bye-bye.